Good morning, everybody. Thanks for coming to the early session at 8 a.m. We really appreciate it. For those who don't know us, my name is Taylor Burkholder, and here with Dr. Emilie Calvello Hynes, and we'll be talking about a rights-based approach to emergency care this morning, specifically about human rights considerations for all of you researchers, educators, and advocates in the audience. Neither of us have been successful in finding anything to disclose. Let's see, I think this actually is our old PowerPoint slides. Do you know if there's been multiple loaded? No. Sorry about that technical glitch. We should have looked through this as it was loading. We can go off cough if we need to. In fact, I'll probably just go ahead and skip through. So I'd like to start by discussing a case from Monrovia, Liberia last year. This echo belonged to a 9-year-old girl who was brought in 2 weeks after her family first sought help. She was living in a village about 200 kilometers from Monrovia, and when her family noticed that she was becoming critically ill, there was no phone number to access help, there were no ambulances, there were no clinics anywhere in the locality, so they started walking slowly with the sick child. They went to several facilities, some which didn't have providers trained to be able to take care of her, others that didn't have the resources to take care of her, and a couple that asked for too much money before she could be seen, and the family couldn't afford it. They eventually ended up at JFK Hospital in Monrovia, where they still were required to pay a bit of money, but eventually were able to come up with that money and were admitted to an emergency unit that was not staffed. There was no triage done. And a couple hours later, after waiting in the unstaffed emergency unit, she was moved up to an open bed in the pediatrics ward, where the pediatrics team happened to be rounding with myself and an ultrasound machine. We saw her in the corner, noticed she was in extremis, put the ultrasound probe on her, and realized pretty quickly that she was in tamponade as the cause of her shock and also had a critical tricuspid stenosis, likely all related to a complication from end-stage tuberculosis. And I bring this story up not because it's tragic. This is an everyday tragedy in a lot of low and middle income countries, but particularly because I think it highlights systematically that her human rights were violated. And I'd like to make that argument as we go through this presentation this morning. And to start this off, I'd like to include a quote from Martin Luther King Jr. He said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And we'll keep that in mind as we go through this framework. So the arguments that we hear often for developing emergency care, both here in high-income countries as well as low-income countries, often involve the pragmatic arguments, those things like how effective is emergency care? Things like the disease control priority estimates that 54 to 90% of all deaths in low and middle income countries are due to conditions that could be treated by emergency care. And that's really impressive. But the legal and moral arguments are also very important and often neglected by us in our advocacy community. The legal arguments involve a complex mix of international treaties, constitutional and statutory law, regulatory policies, and court rulings. And the morals are a bit more complex and hazy, but no less important to the human rights argument. Yeah, these are all slides, so I apologize for this. We'll go through the not pretty slides. So the right to health has evolved since 1946, when it was first mentioned in the Constitution of the World Health Organization. And that talked about having a level of health that's attainable for all. 2 years later, in 1966, was the Universal Declaration of Human Rights by the UN. And this was groundbreaking, and it was the first international treaty to talk about a right to a standard of living adequate for any person, said himself or his family. Besides the bad gender usage in there, it was groundbreaking in that a whole bunch of countries signed on to the idea that there is a right to health now. It wasn't until 1966 that the International Covenant on Economic, Social, and Cultural Rights came out, and that's where you start to hear the term, the right to the highest attainable standard of health. And this was interesting in that it defined the right to health, if we want to abbreviate it that way, in terms of freedoms, like freedom from medical experimentation, and also entitlements, like access to medications. Over the next 40 or so years, there were several more treaties that have been signed internationally, including a whole bunch of very vulnerable groups like children, migrant workers, refugees. There was the Declaration of Alma Ata for primary care as well. But it really wasn't until 2000 when General Comment Number 14 was issued by the UN Office of the High Commissioner. And this is a groundbreaking document because it really lays the framework for how you operationalize the right to health, and how we can then operationalize a right to emergency care if it exists. It is all about the protection, respecting, and promotion of the right to health, and it does so with a few key terms that I'd like to go over now, so that we can introduce the key elements of what we might apply as a rights-based framework for emergency care as well. The first is the AAAQ framework, and this is pretty common across a lot of quality initiatives now, but it brings in 4 essential elements that we need to keep in mind for any rights-based approach. The first of which is availability, so the presence in the population of the essential resources, human resources, facilities, etc., that are required to deliver the care. Accessibility involves how you reach those available resources, and in particular it discusses things like non-discrimination, and especially of vulnerable populations, affordability, and equity. And then acceptability involves a lot of the medical ethics, the cultural appropriateness, and is very important because it is adaptable to the specific population that you're working within. And then quality is a whole bag of worms that I don't think we have time to open today, but is no less essential to delivering the appropriate and best care to the population. Now, overarching to those 4 essential elements are 2 concepts called resource availability and progressive realization. Resource availability dictates that your obligations as a government or an institution depend on the resources that are available to you. So a high-income country like the United States has an obligation to fully realize the right to health, but a low-income country like Liberia does not have those resources available yet, and so they don't have to reach that right away. So as not to give them a free pass, there's a concept called progressive realization, and this dictates that every country, without exception, has to expeditiously work towards the full realization of the right to health. And to start that off, there's a concept of core minimum obligations. These are very important exceptions to resource availability, no matter what level of resources a country has. There are 6 core minimum obligations, 2 of which aren't listed here as they don't relate to emergency care. They relate to shelter and food security. But the core minimum obligations include non-discriminatory access, especially for vulnerable populations, provision of essential drugs, equitable distribution of goods and services, and a national public health strategy. Which brings us to a really important question. The question is emergency care a human right? And I'd argue yes. And the main argument there, the linchpin, is the core minimum obligations. So if we're saying that every country in the world has to, no matter how many resources they have available, fulfill these core minimum obligations, then you can say, how could a government possibly fulfill them without emergency care? Look at non-discriminatory access. We know that accessing the health system is very difficult, especially for vulnerable populations like migrants and refugees. And so having a non-discriminatory emergency care system where a lot of them access the healthcare system is incredibly important. And then you can think about a vulnerable population being any person experiencing an emergency. We've seen documented cases around the world of people being required to pay exorbitant amounts of money before they're able to even be seen or triaged if that's available. And I think that makes them vulnerable to economic pressures. Then the provision of essential drugs is what we do every day as clinicians in the emergency department. Most of the medications we use, I could argue, are pretty essential, and organizations like the African Federation of Emergency Medicine have recently published an essential medications list for emergency medicine. Equitable distribution of goods and services is really what the emergency care system is organized to do. We have pre-hospital systems that get people from the scene to a hospital. We have inter-facility protocols to transport patients from district level to referral hospitals when the resources are needed. So a well-organized emergency care system helps the government fulfill that obligation. And then a national public health strategy is essential, especially for things like disasters and outbreaks. And we know that a healthy emergency care system is one of the foundations to being able to respond to those. So without emergency care, I don't think it's possible to fulfill these core minimum obligations, making emergency care an essential component of the right to health. That brings us into the idea of all of us can be advocates. In fact, for those of us that are clinical, we do this every day. We advocate for our patients. But there's also the high-level, macro-type advocacy as well. So you can use the approach that we just talked, the framework set out by General Comment 14, to develop emergency care systems in a regional or national level. You might start by ensuring the core minimum obligations are met, And you can even map the emergency care system framework by the WHO to individual components of the core minimum obligations, which is work that Dr. Calvello, Hynes, and I have recently been doing and will hopefully see the light very soon. After those core minimum obligations are met, you can move on to progressive realization. For example, maybe you're working in the pre-hospital system in a country. You might have to start with lay first responders, but then as resources are mobilized and international partnerships are formed, then you might be able to progressively institute dispatch protocols, a universal access number, and even EMTs and basic ambulances as well. And as that all goes on, you can continually monitor and evaluate, especially using the AAAQ framework, to make sure that you're using a very patient-centered approach that values the human rights and not just the overall pragmatic impact. So with that, I will turn it over to Dr. Calvello, Hynes. Sorry about the slides. Yeah.
It's really good to be with you guys this morning. Realize that almost every human rights lecture that I've ever heard stops where Taylor just did. And I'm always left with, what the heck am I supposed to do now, right? And one of the things we wanted to make sure we did in this talk and in some of the ways that we're writing about this now is to really unpack what this means. And so what we're going to do for you right now is to go through these pillars of a rights-based approach to health. And here they are listed for you. This is from Sophia Gruskin, who's just a stalwart in the field. But we want to look at this through the lens of what our roles are frequently in academia, both from an education standpoint and from a research standpoint. And I'll pause for a second because this part of the slides is really messed up unless we have the new one. Sir, were you able to figure that out?
The second set of slides?
The second slide. Okay.
No, that's okay. Just a moment. Thank you.
Thank you.
Yeah, that's right.
So just some pragmatism around this from an advocacy standpoint. Listen, concrete practical work around rights-based approaches really requires us to take into account the political perspectives of the governments you're working with. You can't just come in there with kind of your idea, look, we're going to kind of come in with these pillars of a rights-based approach and not consider the context in which you're working. And while it's set forth as universal principles, operationalizing them really requires trade-offs and contextualize political realities. So we wanted to acknowledge that kind of as we move into this. When we consider this for research, right, we're going to go through again our rights-based approach for research. Realize that research ethics certainly has been a very robust field that's been published on and talked about and you guys were educated about. Those principles are very clear for me in randomized controlled trials. They get a bit more fuzzy in the work that we are doing now, and I think a lot of us in the room who are doing global health work are focused on, which is implementation and implementation research. And so I would propose to you that this rights-based approach can really help us be careful and clear when we are doing research in these contexts. And some of those things around transparency and accountability. And so this part of the talk should raise more questions for you guys, but I wanted to just kind of give you a flavor of the things that we're talking about within this rights-based approach. Are there clear and transparent accountability mechanisms in place for decision-making and review? Do the stakeholders have an understanding of where the responsibility lies and where they can bring comments and complaints? Ultimately, accountability, right, the simplest thing we can do is actually measure. And so using quality and access indicators in your research that emphasize a rights-based approach. And with our other slide deck, I would have shown you some of the examples of the indicators that Taylor and I have put together with the human rights framework looking at emergency care systems. I'm happy to share those with you guys offline. And the issues with those is when you look at those things, they are not explicitly human rights indicators, but when framed with a right-based approach, they can be and can really help our advocacy in that way. With regard to research and participation, really the minimum requirements are ensuring that those target populations have been active in the planning process. So for those of you who do global health work, I'd ask you, when was the last time you did this in your work, right? How often are we explicit in including this early on in the process to make sure that all those proposed activities are necessary and acceptable and that the target populations have been really engaged in the design and implementation? When we consider the pillar of non-discrimination in the context of research, certainly you need to be attuned to your own process for human resources, making sure that you are being non-discriminatory in who you hire, right, for your research purposes, but as well as considering, sorry about that, considering disaggregating data and thinking about how do we do that in new and novel ways so that we're ensuring that there's actually not discrimination taking place. And that is certainly context appropriate. I'll give you one example. In my shop, we have an enormous number of refugees who come through our emergency department. If I'm not able to disaggregate the data to look specifically at what their healthcare needs are, I'm going to be missing things, right? And then through the AAAQ framework, so the availability, acceptability, accessibility, and quality framework, we really need to be integrating this into all of our research efforts and asking explicit questions about those. And I'll tell you where those answers lie are really in focus group discussions, right, with the participants. This is one of my attempts in recent months with Dr. Mafi's project in the West Bank. And really, they can really help you identify barriers to implementation. And I'll give you one example. When we did a project in Kenya asking just what definitions were for emergency care for local populations and how folks access care, we came up with barriers we had no idea existed. So there were lots of reasons why bystanders were not responding, because if they actually brought a person who had been in a motor vehicle collision to the hospital, they were going to be held at that hospital until the police came and arrested them because they assumed that they were the perpetrator, right? I could never, ever have possibly predicted that. I will tell you also, though, that you got to check your ear at the door because you facilitating those focus groups is probably the wrong answer. In Kenya, I actually never even saw the inside of any one of those focus groups wherever they took place. We trained Kenyan providers to do those things because I was actually a barrier to getting to some of that data that was really necessary to get, especially about accessibility. So let's transition a little bit to the rights-based approach for the emergency care educator. Excuse me. When we think about this, we can think about it really in two ways, through two different lenses, right? How are we educating our learners, both with accountability, transparency, participation, right, non-discrimination, in the AAAQ framework? It's an interesting lens by which to analyze our own educational processes. And there's been plenty of work done on this, and our education community actually has really given a number of talks here, specifically about discrimination, et cetera. But the thing I wanted to approach for us today was to consider what kind of new content that we can include for our learners explicitly, because I think it's incredibly important. So one of those is our AAAQ framework. This is the easiest thing to do because we can apply this framework to every single patient encounter that we have. If you include these elements in your teaching, you're going to get your learners to think through a different lens. Whether that's the 65-year-old CEO who calls in the middle of the night with an MI, right, or if it's the drunk guy that you've seen for the 5th time this week, right, asking the questions about availability, accessibility, acceptability, and quality of services can really change the conversation that you're having in the clinical environment, and then change the questions that we have about how we're serving the populations in front of us. I think another very important thing as we discuss non-discrimination, I think we as emergency medicine providers think of ourselves as kind of the bastions of, we will take all comers, we're the safety net of the healthcare system. But our learners are going to be practicing very different environments, and what are they supposed to do when they start seeing discrimination happen on a systemic way? I'll tell you just by way of example, I practiced in a unnamed country for a period of time that you may recognize perhaps from the signage, where while I was there, they actually changed the policies of the health system itself and said, those who are non-local are no longer able to access specific hospitals in these cities. That meant for emergency services as well. And what that meant was now there were large swaths of the city where 88% of the population could no longer receive emergency services. We would consider that a human rights violation, right? The government certainly did not. If we're not having frank conversations with our learners about these things, because they are happening, right? They're happening stateside in small ways, they're happening overseas in larger ways, we're not going to be equipping them well to act as advocates that we want them to be. With regard to transparency and accountability, I don't know how many of you guys were actually educated. I don't think I certainly was in my medical school curriculum about what this meant for me as a clinical practitioner. Because we know in the absence of expressed duty to protect and promote human rights, we know that health professionals have served willingly and unwillingly as accomplices in rights violations. We don't have to look at the Nuremberg trials to figure this out, right? We can just look as closely as Guantanamo. And then the concept of participation, specifically with students, both in kind of these issues around human rights violations, but how are we really educating them about how to avoid some of those situations explicitly. This is just one example of Walter Bostonian, who was in South Africa, who really uniformly created some of these very large human rights violations and he was a practicing physician who still has never been censored. He is still currently practicing today. And these people don't start off wanting to be bad people, right? Wanting to kind of commit human rights violations. They start off like all our learners do. And I just wonder if there had been education early on with regard to kind of figuring out how to navigate some of these very difficult political realities, whether that could have been avoided. So really at the end of the day, look, we serve in the field of this incredible specialty, right, where we are able to provide services for people who are really truly suffering, whether that's in Liberia or whether that's here stateside. And no matter what your role, all of us are advocates. And so I would encourage us, as we kind of reach collectively towards the progressive realization of emergency care, that we do that both in our everyday practice and across the world. Thank you, guys.
I might try and see if we can find the other slide deck to show that indicators slide that Dr. Calvello Hynes was, but we'll be happy to take any comments or questions while I'm messing with that. I bet this is it.
Do you guys have thoughts? I guess I'll just make one other comment. The reason why Taylor and I got on this whole subject matter was because I went looking in the literature for when have we actually said collectively as a group of people committed to these principles that emergency care is human right. And I could not find it. I mean, we talk about it every day, right? And we express it in Antala and talk about it with our students somewhat, but we don't explicitly say it. And this is why we wanted to really put this forward in a comprehensive way that really laid out why it is that we should consider it this way. You know, the HIV and AIDS advocacy efforts were really founded on kind of health as a human right, and they use that really effectively. It's a very different landscape now about how we might use that effectively to really push forward emergency care into low and middle income countries. But I think this deserves to be said, it deserves to be taught about, it deserves to be incorporated into kind of our research plans.
What would you say to the notion that it still exists that the U.S. is not signatory to the economic, cultural, and social rights? So it's a little odd for us to be sitting here proclaiming that we should all agree to these when our country doesn't.
It's a great point. Luckily, the U.S. is signatory to the Universal Declaration of Human Rights and also to the Convention on the Rights of the Child. So they're signatory to at least several that do involve the right to health. That being said, it is a bit of a shame, and it looks bad on us. You can still see it in the attitudes of how we advocate as a country, and our government advocates within the United Nations today. There's an upcoming resolution on emergency care that is fundamentally includes rights-based language coming up on May 23rd. And as of yet, the United States has not been a vocal proponent of it, despite having laws like EMTALA for all of its criticisms that do guarantee access to emergency care. So it's a bit contradictory. Thank you.